Maybe, but it depends. If your disease is well controlled and you are how far up from diagnosis? How many years?
Yeah,
a year. It would be worth going back and looking at your chromosomes from the diagnosis, where your status is now. Is the disease well controlled or not? And it may not be necessary to do the transplant now. It may be worth saying, well, maybe we should collect the stem cells and consider doing the transplant. A lot depends on how much therapy you've had, et cetera, et cetera, et cetera. But no, I don't think it's complete, but it depends. You need a full evaluation before I can say in this forum, oh yeah, you should or shouldn't. For me to say that wouldn't be fair to you without doing a full evaluation as to whether or not it's a possibility. It's worth coming in for a visit. And then we can chat about yes, no, these are the issues. So that's why I didn't get, Dr. Gertz wants me to say yes or no and say define a triple or not. Don't know, because there are a lot of variables that you have to go through and make sure that yes, it's a reasonable thing to do, or no, maybe it'd be worth waiting.
I didn't know. Okay, thank you.
I'd collect.
No, I probably would too, but again, we have to see. I have to see what's in your mirror. What if she has mild dysplastic syndrome? We're not collecting.
I'd probably collect.
With MDS? No, I don't think so.
No.
Yeah, I mentioned that because I want to encourage you to wait for this healing. It takes long. It needs this addition of the bisphosphonates. We know that the proteasome inhibitors help to kind of stimulate the bone healing. It doesn't happen in every patient. We don't know why. We don't even know which patients do it. It's not like we can say all patients with an A in their first name develop, healing, and others don't. I don't know. We're in the process of evaluating that, and then we can give more precise answers. I was surprised that 75% of patients showed this positive change, but this is one study, retrospective, in one country, in one center. We have to wait for more information on that to really give a qualified answer to your question. But I am optimistic that we can induce help with bone healing. That's what I can say. And at the moment, it seems that bisphosphonates help with this, at least for a certain period of time. And what's very important is that the disease is in a deep response, so that there's not still disease going on, activating the osteoclasts that then cause even more damage. And yes, if there are osteolytic lesions left from first diagnosis, they can still fracture. So you still have to be careful. But over time, it can develop. And we have really good people in our neuroradiology that can do so-called kyphoplasty, where they put a catheter into a bone and then kind of press the spicules, the residual bone that's there, to the margin of the, for example, the vertebra, and then can fill it with cement. And this helps not too much with the stability, but helps a lot with pain if there's still pain. So they can do that. They are very motivated to do that, and they're very good in doing it.
So a very relevant point. I'll have to say a couple things about my opinion. I think in part, chemotherapy-induced neuropathy is a provider failure. I don't think it's the patient's responsibility to shout and scream, it bothers me. It's my responsibility every time I see a patient to say, how are your feet? Are they numb? They're a little numb, already I'm making changes. I'm not saying, oh, it's just a little bit, it's okay. And in fact, until this business about drugging, I walk in the room now, I have a stethoscope and a reflex hammer. I never carried a reflex hammer for 25 years. But now I keep a reflex hammer because I'm always checking ankle reflexes on every patient, because if they're losing them, I'm getting nervous. So the question is, what about maintenance? Well, in the current scheme, For the standard risk patients, maintenance therapy is not considered neurotoxic. It depends on what you're using, but most maintenance regimens used in the United States do not include agents that aggravate neuropathy.
If your Dr. Gertz is your doctor, you don't have to yell and scream. However, not everybody is as attentive as he is and his team to this. So I always say you have to be very careful. My other statement is there are 007s everywhere, licensed to kill. You have to, again, some people just don't do their job. And I wish everybody would. And I can't say that because I've seen enough bad neuropathy that it pains me, and that really it's the clinical care team's responsibility, and the patient. If you're not getting the right care, you may want to go see somebody else, because I do things. I cannot tell you the number of times I have seen people who are on bortezomib who are not getting acyclovir or something similar to prevent shingles, and they got shingles, or somebody who is on no DVT prophylaxis, deep venous thrombosis prophylaxis, with some type of blood thinner and got a blood clot. And this is really important. And part of it is sometimes people just forget. Sometimes they're not used to taking care of myeloma patients because they're taking care of a gazillion other diseases. That's why you go to somebody like him. That's what he does. He doesn't do lung cancer. He doesn't do colon cancer. If I had to do colon cancer, I'm sure I'd screw up something if I saw one a year. And that's the whole point. You see a lot of something and you get really good at it. So that has a lot to do with clinical care.
Everyone in the room should get Shingrix, period.
Yeah, absolutely. Yeah, but the problem is there's a shortage.
Oh, it's genuine.
Yeah, I know, but in the meantime, no, completely agree. That is the dead varicella vaccine. The live one, Zostavax, you can't get because that's a live vaccine. I'll tell you a story. My wife, who has CLL, ended up getting it. It's a long story. It actually worked for her. But in the meantime, you use Shingrix, because the other problem, though, is you may have to get it again. Why? Because if you're getting chemotherapy, the vaccine may not work, because in particular, bortezomib interferes with vaccine efficacy because it prevents antibody formation, because it inhibits normal and malignant plasma cells. But completely agree. You have to be all over these things, because people will die of infections if they are not properly cared for. That's also my Carthage must be destroyed.
Shingrix, Shringx. It's a kill vaccine
Grix.
against herpes zoster, the virus that causes shingles. Shingles vaccine is important for myeloma patients. The incidence is high, and this is an efficacious agent, even with chemo, and it's not a live vaccine. And you're right, there's a shortage, and it's not easy to get, but when it's gettable, you need it, period.
Completely agree. And this also applies for things like Pneumovax and the flu vaccine. And we have all these anti-vaxxers who think that, the flu vaccine is going to cause autism. It's not. It doesn't. And that is really, really important.
Dyslexia.
Yeah, dyslexia. Whatever. But there are all these measles outbreaks that are all preventable because people don't vaccinate their kids. And I still cannot get around this fact that vaccines have saved more lives than any chemotherapy for cancer. And that's really an important thing to remember in this day, that it'll help protect you and the people who come in contact with you. There's this concept like some myeloma patients don't even get a good response to a vaccine. So you got to make sure everybody who's visiting you is well protected, because you could pick up something from somebody who hasn't had their vaccination. Very important. It's not been studied.
I'm sorry?
It's not been studied.
Okay.
If you look at, there's this place in Minnesota that has these guidelines they send out. And they say at least 2 years of maintenance. And that's based on the French study where the median time on maintenance was 2 years. And the problem with that study is that they suspended maintenance because there was a second cancer risk. And that is the one concern about len maintenance. There is about a 2 to 3-fold increased incidence of second cancers. And in particular, things like leukemia, which can be devastating. So I don't want to be cavalier about this and say, oh, you should stay on it, no problem. But it's not clear who these people are who develop leukemias. We do get concerned in somebody whose blood counts don't tolerate it. There's a concern that they may be developing myelodysplastic syndrome, which is a pre-leukemia type of state. So it's very important to be screened very carefully. If you've got stable blood counts, fine. But right now, we don't have a blood test to say, you're going to have a problem. You should not be on this drug. We're trying to study it. So in aggregate, just to Dr. Gertz's point, where what one size fits all doesn't necessarily apply, I would say that, again, I don't know enough. What were your chromosome abnormalities? How did you do with everything? There's a whole series of issues that need to be taken into account. Maybe do a marrow. Are you MRD negative? Still not a reason to make a decision. It might make, like if you insisted, I have to come off this because I can't stand it. That's one difference between there's no issues. So I think there's a whole variety of things that need to be taken into account. But right now, the current label is until progression. There's no data that would say. There is an ECOG trial, but it's in a non-transplant setting. It's a KRD, which is carfilzomib Blendex versus VRD, bortezomib Blendex. And then patients are then randomized to 2 years versus len until progression. The problem is there's no transplant, which makes it a little bit harder to,
Go ahead, sorry.
Yeah, it makes it a little bit harder to get an answer. So right now, not clear. There are people who want to study it. I'll land the plane. There is a study that's being proposed from the SWOG cooperative group that's going to look at MRD at 2 years and then randomize people to stopping or continuing based on their MRD status. So right now, not clear. There is no hard data. Nope. Then
Go ahead.
No. You're okay. And like 30 years.
He didn't help you, did he? The French did a trial in a non-transplant population of lenalidomide, Revlimid, dexamethasone, 18 months and indefinite. No survival difference, but when you looked at the 18-month, as soon as the lenalidomide, the Revlimid got discontinued, the relapses started. I agree, it's worth having an evaluation. I'm glad you're doing well. You're feeling well. I'm not rocking the boat, and I keep you on it till progression as labeled.
And somewhat, us Germans are not really good in promoting our data, but we have done a trial where we looked into treatment with lenalidomide until CR and then stop. I mean, CR is not really, you have seen the iceberg with a lot going on under the CR water level, but we've done that and have shown that the people that stopped at CR even had an earlier progression than those who went on for 2 years. So it's not answering your question, but it's another sign that going on might be beneficial. There's a tendency that it is rather beneficial.
Until we cure this disease, we have to control it.
I think there will be 3 people here, about 10 different opinions what's right. You cannot generally say what's right. I personally, and I would like to hear your opinion on that, I personally like to change the drug class at least. So patients coming from an IMiD, as Revlimid is in most of the people in first remission, I like to change to, for example, a proteasome inhibitor and or an antibody. We know that a triplet, meaning 3 drugs, of which one usually is dexamethasone, a triplet is better than a doublet in most of the trials. So my recommendation is, depending on your side effects, your age, your duration until your disease comes back, how you were induced, how you responded to your induction, all of those factors taken together will guide us to the decision what treatment is for you. So you cannot say this is it. A lot of pharma companies want to have this answer and basically want to have their drug in second or even better first line or even before you even have myeloma. But I think this is like in drinking water. I think it's very, very individualized. But we have the tools. We have the tools and we have the experience to say, okay, you had a remission of X years, you had an induction of XYZ, and you have the cytogenetics of ABC. And then we can say, okay, for you, we think this is the best thing, and this can even still be wrong. But that's what we do.
So I'm not clear. You're relapsing while you're still getting RVD?
No.
Oh. So you didn't tell the whole story. All right, so you're relapsing on our maintenance post-transplant.
I haven't relapsed yet.
You're on our maintenance and you want to know what to do next.
Yeah,
Okay.
what's the normal?
So that's important. Well, there's no normal, but it's important that, so you're on R, did you relapse 8 months after R, 5 years after R, 7 years after R, and you're going to get a different answer. And so trying to get that pigeonholed, it's one thing, you got transplanted, I relapsed before I even got to maintenance. Or I started maintenance, 2 months later I'm relapsing, in which case, God, what's going on in your bone marrow and the genetics and all that sort of stuff. But the duration, I mean, the only thing I think we would agree on is we wouldn't give you R. And then all of a sudden, it's like antibodies, carfilzomib, pomalidomide, all of those I think are reasonable, but you can't answer that question till you get there because the time is important.
Yeah, it depends, because some people we don't see because we just don't see, and some people get better and then we see them. But also to point out, there is one thing. For example, now, with how people are being treated, all the trials for CAR T cells require that patients be daratumumab exposed. And I can tell you that what's happening is daratumumab is being moved up into where people are being treated for relapsed disease. So I don't know what this is going to mean yet, because does that mean, because once you become daratumumab resistant, it becomes a little more difficult. But if you're daratumumab resistant after having seen carfilzomib, pomalidomide, and all those drugs, as opposed to you're daratumumab resistant and you haven't seen pomalidomide and carfilzomib, we don't know what that means yet. So we have to learn. And then lastly, I can tell you, this is where pharma gets involved. If you're in Europe, the daratumumab has been moved up because Janssen keeps making application to move it up as to frontline therapy or earlier in relapse. It turns out they've partnered it all the time with bortezomib. And I kept wondering, why are they doing that? As opposed to partnering it with lenalidomide, which is a more effective drug. It makes the daratumumab work better. Janssen controls bortezomib in Europe. So there are sometimes not always scientific reasons to do things. There are commercial reasons. So you have to sometimes look beyond that. And to be fair, this is a capitalist system. The only drug that ever came out of the former Soviet Union is bendamustine. Everything else has been
Germany.
East Germany, right? Right. I'm sorry, you're right. The Iron Curtain. How's that? To me, I'm sorry, Stasi was no different. But the whole point is, under our current system, this is how drugs get developed and they brought to market, as opposed to different systems. So it's all unsustainable financially. We cannot sustain this. However, it is a very exciting time because we are able to get all these new drugs because we have this current system of drug development.
I would love to have the answer to that, and I'm on my way to get at least part of the answer. What we looked in this trial was patients at first diagnosis and a CT after the transplant. So it was about half a year and very early after transplant. So I would expect, and there are signs that later on it will be more, because more time gives more time for healing. As I said, small trial, retrospective, not the most valid, but at least a signal that we have kind of this positive effect.
No. We have had one death in about 10 years due to toxicity within 100 days, and that's hundreds of patients. Anybody who has more than a 2% day 100 mortality is doing it wrong. So really, the vast majority of places do not have that. This is a very, I mean, it's not fun, but, oh, you're back. Here.
What, is this mortality on
Yeah.
the transplant? 763 patients transplanted within 1 year of diagnosis with one prior regimen. 3 deaths before day 100 of 763. 1, which was toxicity, and 2 were rapid progression and relapse before day 100. So 1 treatment-related death of 760.
It's no fun, but it is very safe in the right hands. It has to be done properly. The patients have to be monitored correctly. But this is something that is routine.
And so we're clear, all our transplants are outpatient, and the median hospital stay for those 763 was 0. 40% required hospitalization, median 6 days. And over the age of 70, no deaths, 50 patients.
We do them mostly inpatient. It's a long story because we're not set up to do them outpatient. We're working on doing that. But our priority got pushed back on the tree and domino effect. But I think it can be done outpatient, it can be done inpatient, it can be easily done very safely.
Second.
No, well, no, let's stop there. I'm going to act like Dr. Gertz. There is no way with the Shingrix vaccine you will catch it. If he got the Zostavax, it is also not contagious. The only flu vaccine that has been shown to be contagious was the flu mist, which is off the market because you had an active virus in the nose for a week. And that was being very cautious. So anybody can give that. You don't have to have your kids, any little kids can get their vaccines. They can come see you. That's something that, in fact, the American Association of Family Practitioners had a spurious thing about this, saying, if somebody has the Zostavax, they shouldn't go near an immunosuppressed patient. That is completely wrong. We wrote them and told them to correct your website. So this is a physician group that had this wrong. But there is just no data on that. That's something that I think discourages vaccination. I feel very strongly about disinformation on that. I'll have to go talk to Jordan about that. Because it could be you already have immunity, but that still doesn't matter. You should be able to get it. What's more likely is that again, we're waiting till January. Once January and we have the available supply, and had you already gotten it before, the Shingrix or not? You've never had it, right? Oh, you know what it is? Here's why. You see, when they got the label, they were saying that it had to be for people who had had chickenpox. Now, you may have lost your immunity to chickenpox, and theoretically, you're not supposed to get Shingrix. I ignore it. In other words, there's no reason you shouldn't, because nobody gets their varicella titers checked except by us, because we're neurotic about it. So if you want, come see me on my clinic day. We'll take care of it after January 1st. Yeah, we're happy to give you some names afterwards. But there's people both at Strong and at RGH. Yes, except for the flu mist, which is off the market, right? Well, if he's on bortezomib, that may interfere with them working. If he's on lenalidomide, they actually may make them work better. But a lot of times, it just takes a while. And it points out why the immunity of the patient can be deranged by the myeloma itself or some of the therapy. And that's why we keep rechecking titers, because if somebody doesn't bump their titers, they're not protected, so we will revaccinate them. That's why, what we do, it's a center-specific thing. We keep people on penicillin, for example, if they don't have antibodies to pneumococcus, because we're nervous about that. Not everybody does that. But that's one of the highest risks of problems, is people getting a bad infection afterwards, even though they're in remission, because they may not have immunity to standard pathogens or things that we vaccinate against. You got to talk to your clinician, because as Dr. Gertz very well pointed out, just because you got a number doesn't mean much unless you have context. You got to look at the whole picture.
I think the real lesson there is if you're concerned about something, don't stop until you get an answer.
But don't email me. Email McCarthy. I'm very impressed with the antibody data, and there's a slew of new antibodies coming, targeted against different antibodies. So the immunotherapy of multiple myeloma, for 20 years there's a drug called rituximab, trade name Rituxan, which is given to every lymphoma and chronic leukemia patient in the world. That was lacking in myeloma. Now there's 2 antibodies that are approved for the treatment of multiple myeloma, and I think we have more to come. I don't know where CAR-T is going to fall in this, but I think antibodies are going to be a big deal in this disease.
Yeah, the problem with the antibodies is they're against BCMA, which is what CAR-T cells are against. And so we need new antigens. So there's at least, I know J&J has one, and there's a couple others being developed. There's another antigen called April, which is sort of related to BCMA indirectly. So I think I'm interested in immunotherapy, as Dr. Gertz is. I'm not sure if it's going to be CAR-Ts or the monoclonals. There's called duobodies, and then there's bites and all these other things that may allow us to be able to better treat the disease. And I don't know if we have rituximab yet, but that was a huge advance. But I'm also looking into immunotherapy as the way to go.
Yeah, and then combine it with what we already have. Combine those antibodies. That's what we start to do. But I think the combination of the very successful treatment we have with an antibody as add-on, because they have a very low toxicity profile, I think that's very nice. I'm still waiting a bit for the R-CHOP. That's the standard for the highly aggressive lymphomas for myeloma, but I think we are not that far away from that.
With that, I'd like you to thank our speakers.